Triple-negative breast cancer accounts for 15% of all breast cancers here in the United States. And it is interesting that we define triple-negative breast cancer by what it is not. So the term triple negative stands for tumors that are negative for estrogen, are negative for progesterone, these are both proteins, and are negative for amplification of the gene called HER2. So if the tumor on pathological evaluation doesn't have estrogen, progesterone, or HER2, it is called triple-negative breast cancer. So that's why it is defined by what it is not. And even though it is triple-negative and all triple negatives are lumped together, because we're not defining by presence of a unifying factor, they're all heterogeneous. It's not one uniform disease, and that's what is different about this cancer than some of the other subtypes of breast cancer. Compared to hormone-positive breast cancer and HER2-positive breast cancer, the triple-negative breast cancer has a lower survivability rate. Having said that, it is still 70%, which when you compare it to a lot of other solid tumors, is not that bad. But we always put it in context with the survivability of other breast cancers, and our goals are that survivability of triple-negative breast cancer eventually one day reaches survivability of HER2-positive breast cancer. So one advice that I give to all my newly diagnosed patients that I see in clinic is, yes, it is cancer that is more aggressive than other subtypes, but to not just focus on the poor part of it. Focus also on the part that, in spite of all of that, 70% of this is still curable, and we're working very hard with new research strategies to improve that number from 70% to higher. Triple-negative breast cancer within itself is heterogeneous. It's probably divided into several subparts, and some people have classified it to 7 different types within it. Others have put it into 4 different types. Other experiments have put it into 11 different types. But the commonality is that it has different subtypes within it. There may be that certain subtypes of triple-negative breast cancer still have a unifying treatment path that we can capitalize on. And that's one of the things that we've worked on here, is to look at a term called BRCAness, or deficiency in tumors that make them susceptible to certain chemotherapy agents like platinum compounds, or certain targeted agents like PARP inhibitors. And what we've found that within triple-negative breast cancer, about 50 to 65% of these tumors have that BRCAness within that. So if this approach works, suddenly we've taken a disease that may have 6 or 7 subtypes and now simply put it into 2 subtypes, and we can take that BRCAness subtype and use that to identify better treatments. Right away, they should not get on internet and look up triple-negative breast cancer, because what they will read will appear very disappointing. Find a good place that they're comfortable with for their treatment, and for a lot of them, investigating opportunities to participate in clinical trial may actually provide them access to potentially better treatment. Because as we said, the standard of care treatment gives us cure rates of 70%, and we would obviously like to do better. So there are trials in all spaces for patients with early stage triple-negative breast cancer, for patients who have metastatic or incurable form of triple-negative breast cancer. There are trials that are investigating newer ways to treat it, trials that are looking at chemotherapy, which is standard of care, plus other targeted agents, or combination of targeted agents. And for a lot of these women, these trials may provide them better care. And here at University of Kansas, we have lots of options for these women. We have trials for women who have stage 1, 2, and 3 breast cancer. We have several trials for women who have incurable metastatic form of triple-negative breast cancer, looking at different types of targeted approaches for treating this cancer better. I am definitely hopeful for the future. In fact, every time I'm asked to give a talk on triple-negative breast cancer or write a review article, I have to cut my thoughts short, because there's so many new drugs and targets that are being explored for this subtype, a lot more than other subtypes. So we're looking at immune therapy, either by itself or in combination with other immune therapies or with chemotherapy. We're looking at targeted drugs that target the pathway that is PI3 kinase mTOR-AKT pathway that is often upregulated in a large fraction of triple-negative breast cancer patients. We're targeting BRCA that I just talked about, that have targets like platinums and PARP inhibitors. And then there are antibody-drug conjugates, which are like these smart chemotherapy agents where the chemotherapy is attached to a target, and that target attaches to something that the cancer cells express, and the chemotherapy is delivered directly into the cancer cells. So there are several antibody-drug conjugates that are being investigated for triple-negative breast cancer patients, and then there are vaccines. We actually just completed participation in a vaccine study, and we're about to open another vaccine study in that space. So for most of triple-negative breast cancer patients that I see in my practice, they have several trials that they can choose from and even go from one to another if the first option didn't work as well as we thought it would. We started this registry about almost 7 years ago now. And as I said in the beginning, triple-negative breast cancer accounts for 15% of all breast cancers, so it's a smaller subtype. So we need to gather a large number of women with this disease together to understand some of the nuances about it. So with that hope, we started the registry in 2011 with a couple of centers, and over a period of time, we've expanded it to several centers, with 13 different centers across the state of Kansas that are participating in this, including a center in Missouri. This registry has almost 900 patients on it, and women that choose to participate in it allow us to use their clinical information that we can put in the database with all the other women that are part of it, and also donate some blood and tumor samples for future research. And the women that participate in it understand that they are not going to derive any personal benefit from this participation. They are not going to get better treatments by doing that, but they're doing it so the next generation can have better treatments. So I'm really thankful for the support that our patients have provided to this, and it wouldn't have been successful without that. It has really allowed us to learn several important things. The first thing that we reported out of this was the prevalence of germline BRCA102 mutations in unselected patients with triple-negative breast cancer, and we reported that if you are under 60 or meet NCCN guidelines for genetic testing, about 16% of women will have a genetic mutation. And then since then, we've looked at several other aspects, which you can only look at when you have a large population of patients that have entered into a protocol without requiring a specific treatment. So these are women that are getting different types of treatments wherever they are. And women who are coming to an academic center, women who are getting treatment in rural hospitals. And we hope that this will continue to expand further. I've taken on the position of vice chair for Southwest Oncology Group. The NCI funds 5 what they call cooperative groups. NCI is National Cancer Institute, and these cooperative groups, their missions are to conduct clinical trials in the area of treatment, prevention, survivorship, symptom management to improve treatment outcomes. And SWOG is one of them. There are 4 others. And typically, all institutions belong to either one or more than one. We are a SWOG institution. So I'm really, really excited about this opportunity to, number 1, represent KU on the national stage, and number 2, to be able to take my ideas to a national level and help design better trials for our patients. In addition to that, I'm also involved in American Society of Clinical Oncology Scientific Program Committee. In fact, I'm going to be chairing the early stage breast cancer committee for the next coming year, which involves helping plan for the next annual meeting, which is in June of 2019. Association of this cancer with germline BRCA102 mutation, all of that got a lot more understood and in limelight after actor Angelina Jolie declared that she has BRCA1 mutation and underwent preventative surgeries. So as I said previously, 15% of women with triple-negative breast cancer have a BRCA1 or 2 mutation, and these are mutations or changes that one has inherited from either side of the family. And women who carry this mutation are at higher risk for breast and ovarian cancer. It is recommended that all women with triple-negative breast cancer that are under the age of 60 or otherwise meet NCCN guidelines should get tested for this mutation. And whether a person has a mutation or not, at least right now, doesn't impact their treatment decisions, but may down the line as we get more targeted drugs approved for women who have BRCA mutation. But this information has tremendous impact on the decisions for surgery for the other uninvolved breast, the decisions for downstream surgeries to prevent ovarian cancer, and then obviously has a huge impact on family. If a woman is identified as having a BRCA mutation, then each one of her siblings has a 50% risk of carrying the mutation. Each one of her children has a 50% risk of carrying the mutation. So this information is helpful for unaffected family members to decide whether they want to undergo testing and to take preventative measures to prevent cancers. I feel personally that the patients get a more comprehensive care at an NCI-designated cancer center. We have qualified surgeons, oncologists, therapists, social workers, psychologists, cancer psychologists, pain management folks, all under one umbrella. And we can really provide a good care from the beginning to end of treatment, to getting through the side effects, to survivorship, getting back to normal life. That's one aspect of it. And the other aspect is access to clinical trials. We have a very rich clinical trial portfolio on all disease subtypes. And for patients with harder to treat cancer types, access to clinical trials is very important. It is also important for patients who have cancers that have good outcomes with standard of care, because these are the cancers now where we're conducting de-escalation studies, where if you have 100% or close to 100% outcome with A, B, and C treatment, then can we really get away with just doing A, B and avoid the toxicity? So even for patients that have very curable cancers, sometimes participation in clinical trial is to their benefit. We're very excited about our new facility in the south part of town, the Indian Creek facility, and it really provides closer access to patients that live in that part of this city. And it's a women's care center. You know, we have breast surgeons, GYN oncology surgeons, breast oncologists, and lymphedema therapists, and a lot of other facilities. There's a brand new wonderful facility with very easy parking, and the breast oncology will have everyday presence there to see new patients and to help them navigate our system. So we're really excited about the new facility there.
So her stuff could be in there actually.
No, we actually have a freezer designated just for her.
That's the one that you showed me.
So while they're doing,
The one for the blood is in the program.
Oh, okay.
yeah, so like when they're doing high-kiting and stuff, they'll have boxes in here that they use just because it's right here, and then
Right.
they all just kind of get shuffled to there. So they have their own storage unit.
So processing and storage.
Okay, cool.
Lots of different little.
Well, and as I was explaining to her, because it's TV, they won't really explain anything,
Mhm.
which is why it's kind of on me to make sure that we only use stuff that's accurate,
Yeah.
that's not, doesn't require explanation, because they won't have time.
So these, there's nothing, no information on there, right?
Oh no, those are all empty.
Cool.
And do you have an email that you may send a picture of the slide?
Yes. In fact, do I have, no, I don't have a card with me. That'd be too easy to have a card with me. Do I think you have a piece of paper all right on a post-it note?
When does this air?
May 11th.
Is there a time slot?
Yes, but I'll have to look at. Because she had a question this morning that had that information on it. Six p.m. May 11th.
Cool.
And
When-
it'll also be on the website. So
What
she's-
network is this from?
KCTV5.
And I can open up a box.
Perfect. And whenever you're ready. Cool.
Good.
Yep. All right, cool. Thank you.
And then Cliff, I'm going to have him show us the other.
if anything, if you just like open up and then just point to it, point the
Do you
camera.
wanna do it so we know what's in there?
Sure. You're just trying to spread the love, aren't you?
Yep.
I won't be on the video.
Yeah.
Okay.
Mine is 17.3.
Yeah.
Make your
it's
slushy cold fast. And just as an aside, these are the kinds of things that make it dangerous for us to have.
Dr. Sharma will be excited. She takes up so much real estate.
And we're hoping that they say Godwin Labs, so Dr. Godwin will be happy. We can't guarantee that, but we're hoping.